Relapsed CLL is a difficult area to have a succinct discussion about because it's very complicated. It's complicated because it's driven by what patients receive in the first-line setting. It's driven by what's available at the time and what data at the time for treatment for a particular patient. So the choice in treatment for a relapsed patient will depend on several factors. It'll depend on what they received previously, whether it's in the frontline setting or in the salvage setting, because patients can go from first-line treatment, they get their treatment for first relapse, they can relapse multiple times, and the treatments can be the treatments that the patient can be exposed to through time there are many different treatments they can be exposed to. And they can develop resistance to various treatments that they received previously. So the prior treatment, whether it's the first treatment or subsequent treatments, and whether or not patients are resistant or refractory to those treatments will dictate what you give a patient next if their disease is growing and progressive. So if a patient receives, we'll take a couple of scenarios. If a patient receives chemoimmunotherapy in the frontline setting, which is more common right now because we've had chemoimmunotherapy and the integration of frontline ibrutinib it has been a later event, and there are fewer patients who receive ibrutinib frontline today than those who have received chemoimmunotherapy. So if a patient's received chemoimmunotherapy as a frontline setting, in the frontline setting, the treatment options are retreatment with chemoimmunotherapy or going to a BTK inhibitor or going to venetoclax plus rituximab as an option, because we heard at ASH about the Murano data and clearly outcomes were better for patients who received venetoclax plus rituximab over bendamustine rituximab in the relapsed setting. So frontline chemoimmunotherapy with a reasonably long remission, it's reasonable to think about chemoimmunotherapy again. That would probably be less common these days than moving to one of the small molecule inhibitors. If a patient has had chemoimmunotherapy before and doesn't have a 17P and has acquired 17P, when they need their retreatment, they need to go to a BTK inhibitor or to venetoclax-based therapy. If they don't have 17P, if they've had a long remission after that first chemoimmunotherapy, it's not unreasonable to think and have a discussion about chemoimmunotherapy, but I think right now the preference would be to move them to a BTK inhibitor like ibrutinib. And more recently, the Murano data would support using venetoclax plus rituximab also in that setting for relapsed disease. So in the relapse setting, we talk about prior chemoimmunotherapy. We can talk about prior ibrutinib therapy. So if a patient has been on ibrutinib as their first treatment and their disease is progressing, or if they come off of treatment because they have some toxicity, next treatment would be a good discussion. You could have a discussion about chemoimmunotherapy. There's less data about how well chemoimmunotherapy works in that setting in patients who have failed ibrutinib. There is some data that supports the use of venetoclax in that setting. So venetoclax plus rituximab would be a reasonable option in that setting and probably would be my preference as next therapy. And I think as we get more data and as time goes on, we're moving more away from using the chemoimmunotherapy in favor of using the small molecule inhibitors. So moving from chemoimmunotherapy to an ibrutinib-based therapy to a venetoclax-based therapy, and then third line would be PI3 kinase inhibitor-based therapy would be the general sequence of what we see today. Now that's going to change because, as I mentioned, more patients are getting ibrutinib up front, where we might see ibrutinib first, followed by venetoclax-based therapy, followed by PI3 kinase, and chemoimmunotherapy is somewhere there, probably more likely prior to transplant. If a patient has progressive disease and they've failed several prior lines of therapy.